Good day. Welcome back to Faculty Development, Teaching and Learning in Medicine. This morning, we're going to be talking about something that's really important, giving feedback to our students, our residents, so that they'll be aware of their actions that are optimal, the things they're doing right, and we as teachers will be able to provide them insight so that they can change their behavior, they can learn how to do certain aspects of their clinical care a little bit better. Teaching and Learning in Medicine, the Art of Feedback. I'm really thrilled to have two of my senior family medicine residents here with us this morning. Dr. Daniel Law. Morning, Danny.
Good morning.
And Dr. Pira Sham.
Good morning.
Second and third year family medicine residents who've come to talk about the art of feedback. So let's get started. So what does feedback mean to you, Danny?
It means that when I'm on the floor and I'm working, that I'm getting an outside opinion of how I'm doing.
Okay. Is that valuable to you?
Oh, very, very valuable.
Why do you think we're spending a whole session on just one idea of giving feedback?
Because we want to know the areas we need improvements on and areas that are strong points and our weak points.
Feedback is pretty important. In fact, the LCME that accredits medical institutions requires that in our clerkships, somewhere in mid-clerkship, get our students together with the people who are teaching them clinically and officially, formally provide forth feedback. So the question is, when should we be giving feedback? Why do we need to give feedback? And how can we best do this in the setting of clinical teaching? Clinical teaching is something we almost do intuitively. And Franz Reichman says, though, that it's very unique if you look at all of teaching that goes on in the realm of teaching, because in no other field does the nature of the material demand of the teacher this degree of preparedness without preparation. When you go in to see patients with students and to work with them clinically precepting, you don't know what patient's going to come in, do you?
Nope.
So not only don't we know exactly what we're going to teach the students about, we also have kind of a tripartite type of learning. You're talking about knowledge. What do students need to know about pain or a particular illness? You're talking about skills. How well did they do a physical exam? How well did they structure that history? But you're talking about attitudes also, knowledge, skills, and attitudes. Where do you think they learn about being a professional and about developing their own attitudes towards patients?
I guess they would observe us first.
That's right.
As an example.
That's right. They learn from the people that they work with and who supervise them. So Danny, how did you learn how to treat patients?
I learned from watching my attendings, how they act and how they respond to patients and how the patients respond back.
So everybody learns from their colleagues and their supervisors. You learn from your attendings and the medical students learn from you. When you work with students, what do you feel the students are looking for?
They're looking to learn how medicine works and how not only the knowledge, because they've gotten that in medical school, but they also want to see the interactions. And they also want to see how we approach patients and how we get information needed.
A lot of it is experience, but a lot of it is thinking, putting the pieces together. How easy do you think that is for students?
At the beginning, it's not easy at all. But I guess after a while, it comes with time.
You're right. At the beginning, they have to struggle. What are the pieces in the history that are important? How they're going to put them together? It's very difficult. It's really, sometimes students who are good at memorizing or good at taking exams have never had to put those pieces together. And feedback, by using feedback, we can help them sort all of this out. Medical students, especially in the beginning, and especially when they just start third year, are going to run into trouble, aren't they? They're going to extract a lot of extraneous information, and they may miss key things because of the lack of experience. For example, in the patient with chest pain, they may not have asked about dyspnea on exertion, which to us is key. So I guess here's what we're going to do. Pira, you're the medical student who didn't ask about DOE. And guess what, Danny?
I'm the resident.
You're the resident. What are you going to tell her? She just comes in. She's all excited. She has this patient with chest pain. She presents this voluminous history, and she never asked about dyspnea and exertion. What are you going to tell her?
Pira, you did a great job getting all the history. But what do you think in particular is causing this chest pain?
Maybe musculoskeletal?
Okay, let's go over the differential diagnosis. So you have the muscles. What else is in this region that can cause chest pain? I guess in this whole region up here, in the chest.
The GI tract.
You have the GI. What else? We also have
And the lungs.
the lungs. Yes. So what kind of questions would you ask on specific, the lungs, the GI, the heart? So in the lungs, what would you ask a patient?
How they're breathing in.
How they're breathing in. Also, if they have shortness of breath.
Okay.
Okay. And if they have shortness of breath while walking or moving. How about the heart? What would you ask them about the heart?
If there's any palpitations, and more regarding the chest pain.
Yes. So I usually try to extrapolate the organ system and let them try to figure it out.
So you're trying to get them to think into a differential of understanding why dyspnea and exertion would be related to coronary insufficiency. Okay, you're not only giving them feedback that they miss dyspnea and exertion, you're helping them think their way into it. And that is an excellent technique to use. At Downstate, in terms of feedback, we call giving feedback serving the SUNY Downstate sandwich. Because in truth, sometimes it's difficult for an attending to tell a resident or a student sort of giving the bad news. And they avoid it, right? We've all seen that. So one of the techniques that we ask our attendings and our residents who are teaching to employ or to use is to tell a student what they did was good. And you did that with Pira in your modeling. You said, you took a really good history. I want to explore a little bit about your thinking. Tell them how and what should be improved. So the one technique I would do is after you go through this thinking, you would say, I've concentrated on the heart with you. The reason is because there's a wide differential here between the GI tract, the lungs, and the heart when we're talking about chest pain. Dyspnea, shortness of breath on exertion, will be key for coronary insufficiency, and it's going to be a major killer of patients. It's something, even if we think it's down low on the list, we're going to work it up first. And that's the kind of feedback. You tell them how something should be improved and how to do it. You begin where the learner is. And Danny, that's something you did with Pira. You started by looking at where she was in her history, what's in the chest pain, but then you went to what you thought she would know about, which is the anatomy. And you tried to relate your history to the anatomy, and that's a fabulous technique. So you tell them what was good, you can tell them what could be done better or how they should change their thinking, their behavior, and then tell them what was good again. So, how do we give feedback? Well, feedback is different from an evaluation.
The attending actually met up with us during half the rotation.
So at halftime.
Halftime.
So this is like football. If you're talking about feedback, it's kind of like football. You have to have a halftime. And you're right. Because as an attending, I have to know where you are, and it's going to take me time to find out. But I've got to get you that feedback before you finish. So it's kind of like a halftime thing. Go on.
Yep. So halftime, he gave positive feedback as well as what we needed to work on.
Together or one at a time?
One at a time.
Yeah. Well, why do you think we should really give feedback one at a time?
So leaving room for improvement also. So half the rotation, he evaluates us, he gets to know us better.
Good.
So, and for the latter half, giving us some time to work on our, weakness and to strengthen our strengths.
And improve.
Improve. And he evaluates again. Okay,
so evaluation is something you get at the end. You can't change your behavior. Feedback you can't get right at the beginning, but halftime sounds like a good approach. Now, what's the difference between a positive feedback and a compliment? Give me an example of a compliment. Give him a compliment.
But I guess great smile.
Okay, Danny, you have a great smile. Now, think about this. Can he change his behavior? It makes him feel good, right?
Yes.
But it sort of doesn't lead to any change in behavior. Okay, that's something that's more social, more friendly. It's not quite as professional. So when we're giving feedback, follow that resident or student around until you see them do something good, perform in their professional capacity. Just don't try and fish around for something good to say about them, because it can actually be inappropriate and get you in trouble. You know? Wouldn't you rather hear, Danny, you take a great history of present illness, but you know, you're skipping over the work-related and sort of social history. Because while you're taking a great history of present illness and you have all the dimension, you see, pick things that are professional and related and mean it. Because you can always find things that folks are doing that are right and help that student along to do a little bit better. And it works the same for negative feedback, the things which is a little harder to give than positive feedback, of course. But it's easier if you say, you've done this and you can do it better by perhaps thinking about doing it this way, because then you're giving the student something to do. You're beginning where the student is at. They know what to do. Feedback begins where the learner is, and feedback is measurable and behavioral. Be very careful. Don't be personal in your feedback. Be behavioral. Because remember, once you start getting personal, who do you become? You look so sloppy when you show up, blah, blah, blah. Yeah, you begin to become their parent. You don't want to begin to become that. You don't want any of that dynamic. You want to be the professional mentor. You want to be like the attending. And to attend is to work with someone, to walk with them. And that's what we want to see. So feedback is information that's given about current performance and how your students or your fellow junior residents are going to improve it in the future. And it's really important that you observe. And as you said, halftime, I think that really brings the point across, that it be documented. And one of the things we ask on our clerkship is that we tell the students, give this evaluation to any attending or resident that you've worked closely with. Leave it with them for a few hours and then ask them to review it with you and talk to you about your performance. What you did was great, and what are some of the things you could do a little better. So sometimes to even have somebody write it down just makes you think that they thought about it and it's documented. It should be specific, and it should be something in terms of performance, always performance-based outcome, and to try and stay away from the compliments and criticisms as much as you can. And how do we say feedback is different from evaluation, Danny?
Well, feedback is something that's ongoing.
Right.
And evaluation is at the end, how you perform throughout the ongoing month.
So they're related, or the ongoing 6 months, right? They're related, but they're very different. One is ongoing. It gives you a chance to change your behavior. And one comes at the end, and it's like, that's it. This is how you did. Which one is more valuable to learning, Pira?
Feedback.
But if learning is really about changing behavior, and that's what it's about, feedback is critical to learning. And I think that's why the LCME gives such an importance to feedback. And it's so, we're all so busy, it's easy to miss just giving that message back. So learning, again, is promoting a change in behavior. Feedback should be formative. It's the opportunity to change, to reevaluate, and maybe to change again. Positive feedback is going to be professional, specific, behavioral, measurable, and it kind of keeps everybody working together, as opposed to a compliment. The things that you look for in one student or learner, look for in the other. So make sure that you're using the criteria for that level of training. I, as the chair of the department, look for something differently from a third-year resident than I do an intern or a third-year medical student. That at different levels, we expect people to have different levels of knowledge, skills, and attitude. When we give feedback, it's so important that we begin where the learner is, and it's so important to avoid criticism. If you look on the right, you have the picture of the judge. Criticism, personal, evaluating the demerits, and you judge accordingly. We're not here to give criticism. We're not judges, but we can identify, like the attending, kind of pulling, you notice this could be you, Pira, pulling those students up that hill. Or the negative feedback identifies those specific behavioral, measurable performance, which should be important. Choose your feedback wisely, because you want to hit on the things that really matter, that are important to that resident, that medical student becoming a professional provider of health care. And we know the key to success here is specific. It has to be pick one thing. The feedback that you provide them is so critical to their learning. And all of us, I think, as teachers have to remember that. So, Pira, any closing thoughts on the art of feedback?
It's definitely an art. No, I agree with what you say.
So it's a skill?
It's a skill, and it goes both ways.
That's right. It's a skill that goes both ways. It's something that's formative. It's something that's critical. And it's going to take time. And like any skill, practice makes perfect, but you're really never perfect. You are our teachers. But at the same time, you give feedback. You also should be receiving feedback from us. So it's been really a wonderful opportunity. And I want to thank you.
Thank you.
So today we've talked quite a bit about providing our learners with the opportunity to improve their behavior by giving them information that's specific, measurable, that will help them to improve their performance. This is given during the course, not at the end of learning, not at the end of a rotation, but as we heard Pira so expertly demonstrate, during halftime, so that we provide our students with a methodology, a way, a process, an approach to change their behavior, get a little bit of history, perhaps do a better physical exam, but certainly to change their behavior in a way that will help make them a better provider of care. Thank you for your interest and attention, and we look forward to continuing to discuss how all of us can be better teachers and learners in medicine. Thank you.